I'm very happy to host this webinar, and I'm very grateful to Metron for asking me to address a topic I'm particularly devoted to. And these are my numbers, and especially my personal mobile phone you can use for very welcome WhatsApp messages. And the purple circle highlights what is essential and absolutely necessary features. Ranking first by importance, continuous patient remotivation, followed by effective physiological therapy, and the non-surgical approach, of course, as always, at the first therapeutic phase. Everything that has been listed below this purple circle, including laser therapy, that is absolutely additional, not absolutely necessary, and never to be considered as a monotherapy. What is absolutely necessary is manual and ultrasonic instrumentation. I explained everything in my book that was published in Italian in 2015 and in English in 2017, and concerning as well ultrasonic instrumentation. This in chapter 3, I always give a lot of technique listed and explained step by step, and trying to also make very good tips and tricks that I will describe in this presentation, especially in a very short but hopefully very didactic video clip. In the first visit, of course, I introduce the patient to the patient my periodontal probe that has mark, and I say that up to 5 millimeters, I should be able to manage in a non-surgical way. However, in the first, after collecting all the periodontal indexes, I come up with the clinical diagnosis will be the same all over the world, unequivocal and certain. However, the treatment plan can be different. We'll see in the following patient, Ada, Mauro, and Angelo had a very similar problem, but they have been treated with a different type because of their chief complaint mainly. So the treatment plan is also to be specific, in that case, specific to their main complaint, and always customized. This is Ada. Ada came because she didn't want to lose the tooth. She had a 10 millimeter pocket, some recession, and she wanted to have a good aesthetic, ranking first. Then she wanted to have health and also function. In that case, we decided to approach with the surgical approach this area, and refrain from doing initial preparation in this in this future surgical site. Of course, she came for a prophylactic appointment that was extended to the rest of their oral cavity, but we didn't use the ultrasonic in the site that to be managed with the regenerative technique and periodontal surgery. We might have used laser because it doesn't remove the mineralized deposit. It only has the bactericidal effect if used alone as a monotherapy. And then when with the open flap, then we can use ultrasonic instrumentation, and of course, along with the regenerative technique, of course, following the removal of the deposit that were found along the palatal sulcus, which seems to be like a high-speed highway in order for the bacteria to get deeply into the pocket and create this big periodontal lesion. Also, you can see that because of recession present, a connective tissue graft was harvested from the palate, and then it was placed in this area combined with the papilla preservation technique, and also we wanted to have tension-free flap in order to avoid any sort of complications in the follow-up healing period. We see that we had a very good, encouraging clinical and radiographic outcome at 12 months post. And she came for a second opinion, actually, because with the same clinical diagnosis, a different dentist suggested to remove the left central incisor and to place an implant. But we can see that she was very satisfactorily treated with the surgical approach and the regenerative technique. Here, the clinical and radiographic 5-year follow-up. This is Mauro. Very similar problem, but his chief complaint was health. He wanted to restore health, and he wanted good function, and he wasn't interested in aesthetics so much. Even though the bony lesion was a vertical type and quite deep. We took a picture because I want to make sure that Mauro could cope with like a triangular black hole here in case of recession following my instrumentation. He accepted that secondary effect, and I did a very aggressive type of instrumentation, and of course I mainly used the ultrasonic insert, the very thin ultrasonic insert, especially in the palatal aspect of the defect. It's much more convenient compared to manual instrumentation to me, along with the laser treatment. And this is the clinical and radiographic outcome, especially of Mauro, that is included in a case series article published in 2016, where I was able to get a mean clinical attachment level gain of 4 to 4.4 millimeters in single rooted teeth. And in a follow-up retrospective control case series with another 25 cases published in 2017 with the 10-year follow-up, I was able also to improve in multi-rooted teeth, and quite unpredictably, absolutely unpredictably, even furcation involvement was pretty much improved. Of course, the second mandibular left molar was removed because it was a hopeless tooth, and you can have some bone apposition, regeneration, remineralization in this area. However, the furca fill is quite unpredictable, however, seems to be possible by this case that has been published. Again, similar situation in Angelo. I saw him 7 years ago. This is the full mouth x-rays, and he has major problems in few sites. However, from a non-dental perspective, I see that Angelo has a very nice smile, good teeth, nice pink gingiva, well stippled, and with the scalloped papilla filling the interproximal space. Everything seemed nice and fine. He's only complaining because he has some slight mobility and he has some function problem. He wants health and he doesn't care for aesthetic as well. But when I go probing, I see like a 9 millimeter probing distally to the lateral incisor. And when I take a picture of Angelo's smile, I see that it's so clever that he is revealing the left side and maintaining covered, and he's able to hide the critical area when he's smiling. So I took, of course, periapical x-rays from the full mouth x-rays, And we can see that is quite challenging, this type of situation. And the periodontal probe totally is sinking in this Grand Canyon periodontal pocket. This is a paper note that has also the price list and a possible invoice that can be done at the end of the treatment when he accepted the ideological therapy, which is composed of several appointments according to a protocol that I've been implemented for almost 20 years. And so in the first 2-hour appointment, I remove all the supragingival deposit, and that's taking about 15 to 20 minutes. And I use a regular standard type of insert that is able to remove the calcified deposit, mineralized deposit that are very abundant in a supragingival area. And I try to move from one side to another in order to safeguard patient comfort all the time and not to stay for a prolonged time in an area, and that can result a little bit annoying to the patient. But there is not a particular technique beside that in order to use effectively the supragingival instrumentation with the ultrasonic device. Different is when you go subgingivally, and when you go subgingivally, you need to identify the deposit that they have to be removed. Of course, you need the probe to measure the periodontal pocket, and you want to start your non-surgical instrumentation from the most apical part of the pocket and work your way coronally. And alternatively, I use the ultrasonic instrumentation, the laser, if I have the laser. Alternatively, I can use a disposable syringe filled with hydrogen peroxide, diluted with also some antimicrobial substance in a dense form, in order to have to increase the substantivity of the antimicrobial substance that I deliver subgingivally. And then I alternate with the manual instrument. Very few manual instrument I use, but extensively. And when I do go subgingivally, I select an ultrasonic insert, which is thin, straight, and is able to go subgingivally in a very proficient way. But before doing that, I must assess the site-specific need for periodontal instrumentation, even in the very beginning where there is a lot of deposit to be removed. However, I never do a standardized type of instrumentation. I do prefer to check with the probe and assess the distribution, the morphology, the quantity of the deposit to be removed. And then I go with the ultrasonic insert. I go subgingivally with the ultrasonic insert, and before activating the device, so I go with the insert, with the ultrasonic off, and I use the insert to very meticulously perform calculo detection and fill the deposit with the insert I selected to remove them. And in this way, I am really, I have a very good picture of what my job is going to be professionally in order to remove it effectively. So I have a baseline information to compare to the ongoing type of situation. And then when I step on the foot pedal control, activating the device, I make sure that the insert is moving, is not static, because that will give a hammering effect, very annoying to the patient. So I make sure that he is, oscillatory movement, shaking almost on sight, but is not still. The instrument is not still; is always shaking. And these now maybe we hand up the first appointment. At the second one or the following appointment, I have to repeat the same type of procedure. So I won't go to the probe first with the insert, secondly, in order to check the residual deposit still present, and they have to be removed. So that is quite important and makes the difference, because we don't want to over instrument, over treat. We don't want to do over treatment on one side, and we don't want to do under treatment in another side, but just to do a very site specific type of non-surgical instrumentation in order to remove all the deposit we have detected. And then at the end, the periodontal probe will check, and the final assessment, the final evaluation, or a very smooth type of deposit, smooth surface, free of any deposit. In case we use the laser, we do it before the instrumentation, because we know that it inverts the sodium potassium pump at each cell membrane. It has a bactericidal effect, so you reduce the microbial load, and also it can act weakening the adhesion between the root surface and the calcified deposit. It doesn't remove the deposit. It does not remove the deposit. This type of diode laser. Other type of laser, they do, but this does not. So it's something adjunctive, is always adjunctive, and to remove the deposit, you need an ultrasonic and manual instrumentation. It's very important, because these are all the diode laser effect listed. And also when you clinically use, you want to use it also before the instrumentation, because it helps you to detect with more remarkable tactile sensitivity, because the dimension of the laser insert is thinner than of any periodontal probe that we know, because of its dimension. And then we alternate subgingivally the use of, in case of laser treatment, with the use of ultrasonic insert, very thin, in order to reach the base of the pocket, and working with the ultrasonic, starting for the most apical portion of the pocket and working coronally, going coronally. Of course, we alternate with the manual instrument that have to be used both vertically, with vertical type of strokes, as well as horizontal type of strokes. And with the vertical, I use the tip-only technique that I described in my book and in every other type of my presentation. And also the ultrasonic has to be used very carefully in order to remove all the deposit present, and check again with the probe or with the laser, alternating the use with the ultrasonic device and manual device, which are essential type of etiological therapy. Then I see the patient for the first recall appointment after 3 months, and I do a very gentle probing. So, because in case of pocket closure, like I can see here, I very gentle, I call superficial probing with a very low pressure, because I know that in 10 days, a 5 millimeter long junctional epithelium will be fully formed. However, its adhesion to the root surface is very weak. So if I apply normal pressure, this will unzip will open like a zipper. So that is why I have to be very gentle and just try to reach the most coronal portion of the junctional epithelium, long junctional epithelium, and not to detach it. Because we know that it's rolling down from the external epithelium, is rolling down with the external oral epithelium at a daily speed of 0.5 millimeter. So, as I said, 10 days will be enough for a 5 millimeter long junctional epithelium to fully form. However, in order for the connective tissue healing to take place, we need about 4 to 8 weeks. However, for all the other for the fibers all the network of fibers to fully form, especially the circular one, they have a very contentive type of effect. We need much more time than 8 weeks. And as Professor Lang said, tissue needs time to heal. That is why I prefer to wait for a year before doing reevaluation. But I don't wait a full year and not seeing the patient. Okay, I keep monitoring my patient, and I disagree a little bit on what is stated on literature, because they proposed as the ideal time between 8 weeks, so maximum 2 months. I'm sorry, maximum 2 months as the ideal time for a reevaluation. But in the previous line, the same article stated that longer than 2 months may be too long to wait for reevaluation, because pathogenic bacteria have already repopulated the periodontal pocket if you don't see the patient. But if I keep monitoring and I don't only check my patient, but I see every 3 months, and I remove newly formed biofilm deposit, but also I check if I left something behind that needs to be instrumented, as in Sarah. In Sarah, the next patient I will show you. Now we are talking about Angelo now, okay? We are still talking about Angelo, that I see Angelo every 3 months for the first year. And I prefer to reevaluate and both radiographically and with the periodontal chart in writing after a year. So, because there are also articles that are supporting what I'm saying now, and this is the Angelo baseline and 6-month follow-up, same Angelo baseline and 9-month follow-up, and then 1 year I really check and I probe with regular pressure, and I take an x-ray because I want to make sure that that type of mouse-eaten bone and very regular profile has more quality, as remineralized. And so I also do a new periodontal charting once a year, even though at each recall appointment are circumferentially probed to update the diagnosis, which is a responsibility of mine. Then the full mouse x-rays can be repeated at 4-year follow-up. So now we are 2017, we check and it's fine. We see a nice lamina dura on the interproximal area here, and I see then the recall appointments be stretched a little bit. I don't see Angelo on a quarterly basis, that is every 3 months, as I did, and it's very important in the first year of follow-up, especially in periodontally advanced cases, as Angelo, as Mauro, and as Ada in the first place, and Sarah in the following cases. But I see monitoring every time, doing circumferential probing, and I see that here this clinical site has become unstable, okay, as defined by the new classification. So this is unstable clinical site. Almost 5 millimeter probing depth, 2 millimeter recession. So I check again on the slide and I said, if I do instrumentation, would you cope with the more recession, or do you prefer to inquire for a surgical management, a surgical approach? And Angelo said, no, it's okay to go non-surgically again. So I did a very aggressive manual instrumentation. You see a sickle scaler here with a horizontal stroke that is oriented palatal buccal, okay. And then also the ultrasonic instrumentation, which I do, and I is absolutely necessary, and I alternate with the probe or laser in order to assess if there are residual, very tiny, minute deposit to be removed in order for this site to heal following non-surgical approach. And I strongly recommend to use a disclosure solution, not at the beginning of the appointment in these cases, but it's so important for me following non-surgical periodontal instrumentation, because I want to check on my clinical performance and make sure that maybe the sites needs some additional instrumentation detected by the disclosing solution. And of course, I want to make sure that the patient has acquired the necessary home care skill. So here we have the interproximal space that is ideal for the use of the interproximal brush. And even a medicated gauze can be used and wrapped like a C shape around each of the two adjacent teeth in this area, and used like a shoe shining motion. Very effective, very easy to perform. Then another year has passed by, so I document and I go and probe with regular pressure, and I have a 3 millimeter probing reading and 2 millimeter recession. So a total of 5 millimeter clinical attachment loss and BOP negative. And these now we have 7-year follow-up, stable, 2 years from the critical, with the clinical unstable situation in this year, 2-year follow-up, and 7-year total from baseline. And this is the baseline and comparative 7-year follow-up periapical radiograph. Another site, same patient, same Angelo, and here in the multi-rooted teeth, we were able to reduce the initial 10 millimeter probing depth to 3 millimeter probing depth 7 years later. And these are the comparative x-rays of the site. I always suggest my colleague to use the probe also to check the stability of the mucogingival seal, with the probe held perpendicular to the long axis of the tooth and applying slight pressure in a apical coronal direction, like that. And we, same Angelo, different site. At baseline, we had 1 millimeter probing depth, and also we had some 4 millimeter resection for a total of 5 millimeter clinical attachment loss and only 1 millimeter of attached gingiva. Not really a mucogingival problem that needed a surgical management, however, something to monitor quite carefully. And so did I. And up until now, we have some has not get worsened, and so it didn't need any surgical management. Patient doesn't experience any sensitivity, any always I have to be very careful when I instrument this area, even with the ultrasonic and the ultrasonic and the manual instrumentation. The manual instrumentation mainly horizontal stroke with the ultrasonic device, very gentle strokes here, and it maybe I use disclosing solution in order to do just the right type of treatment as needed, site-specific treatment. And this is 7 years follow-up. We can see that the situation is not as a stable clinical situation, and we didn't do anything else but a non-surgical approach. Then we go back and we look at the posterior mandibular right first molar that had 15 minutes probing depth at baseline. The patient, as I told you, didn't want to remove, even if it was an hopeless tooth, and it was chewing, it was functioning. I took an x-ray 6 months later just to see if it was safe enough to maintain, and the tooth had been splinted to the second bicuspid adjacent tooth, and of course occlusal adjustment was needed from time to time in some recall appointment because we of course check also the occlusion of that site. And this was the situation in 2017, but then in 2018 we decided for some treatment because the mobility has got worsened, and we proposed Angelo to do the following treatment, checking on all the. So we the endo treatment was performed by my daughter in the two roots, the major roots, and then it was the second molar was extracted, and we saved the full crown of the first mandibular molar, and the four teeth were splinted together from the second bicuspid to the third molar in this area, and we gave the time for this site to heal, especially on the bone component. And you see how it was a very quite a big defect to place an implant at this time immediately after the removal of these. You should have like a lot of regenerative technique or to wait a lot of time. And in the meantime, this type of solution can be very cheap for sure for the patient, very convenient, and it has proven to be worth it, as I can show you, because this was in 6 years, after 6 years, and this is after 7 years. Angelo now, we recently saw him, 7-year follow-up. You see now how the bone profile is more mineralized, the years, really. And now we can do any kind of treatment, place an implant, remove the splint, and so forth, do a single crown, do any kind of treatment can be performed much easier. Or keep on, Angelo for now prefers to maintain this situation because it can chew and function in a very satisfactory way. And for now on, we are not rushing him into implant therapy for the time, but we have the opportunity to do it, as you can see, in the future eventually. This is Sarah. I told you, Sarah. I have all these are, I'm sorry for the quality of the picture because these are screenshots from video clips. So I documented mainly with video clip that I will be willing to share with any clinician. And I did the same protocol as I described for Mauro, Angelo, and everything. And for the follow-up, I see the patient every 3 months for the first year. Absolutely all those cases, they are very severe, like grade C or stage 3 or 4, according to the new classification. I wanted to see every 3 months on a quarterly basis for the first year. And Sarah So now this is the second follow-up appointment at 6 months. So I saw Sarah, instrumented Sarah already five times, four appointed according to the my protocol, and then she already came for the first 3 month recall appointment. So I already instrumented 5 times, and I have a reduction in a multi-rooted tooth. This the molar, the maxillary molar, and three. So he had probably furcation involvement. She had furcation involvement, and so forth. So I would say that I perform a quite satisfactory initial preparation for preparing this site for a surgical management. And usually in the past, when I was used to reevaluate the clinical cases either after 3 months or after 6 months, of course, these the ideal treatment, the needed, most indicated type of treatment would be a surgical management of a 6 millimeter bleeding or probing positive site. And the baseline radiograph showed a vertical defect, quite important, like in Mauro. Only Mauro was a vertical defect on the anterior single-rooted tooth. So easy to get access to was an advantage. Here was not as deep as in Mauro, but it was in the posterior area, difficult to get access, and also a multi-rooted tooth. So it's a quite more challenging type of situation to cope with, to deal with. And then I suggested and asked Sarah if I could perform some additional instrumentation, some additional aggressive instrumentation, like 6 millimeter was my initial probing depth. I wanted to decrease and to reduce. So she agreed upon, and I used also the laser, of course, but the essential, absolutely necessary instrumentation are the manual and the ultrasonic device, because I repeat again, they remove the deposit, the repose calcified mineralized deposit, and while the laser, if I use it, only has a bactericidal effect. It weakens the adhesion between the deposit, but what it actually does, the removal, is something that mechanically works with the manual curettes and the ultrasonic device. And so we see Sarah now at 1 year follow-up. So from 6 millimeter, we were able to decrease it to 2 millimeters POP negative, but we started from 8 millimeter baseline probing depth. And so it's quite an accomplishment. But we want to take, as I told you, I repeated the all-day periodontal charting at 1 year follow-up. And of this site, they are quite critical. I prefer to take an X-ray at 1 year just to make sure that I had some also remineralization. Of course, this is not regeneration as in ADA. ADA, that we did the surgery on the central incisor, okay, that we use the regenerative teeth, and that is bone that has been regenerated. This is bone that has been remineralized in a posterior area with the vertical defect, which is not predictable, however possible, because we are far behind the threshold, the predictable threshold according to the evidence-based literature, which is 5.4 millimeters, I will tell you shortly. Same patient, different site. In 6 months, I decreased the probing depth from 7 to 4 millimeter, but 4 millimeter is not a critical probing depth to be considered indicated for surgical management. Is considered over treatment. So of course I instrumented that area aggressively as needed, in a site-specific fashion, and the improvement was significant. Also in this site, 7 to 3, and of course these are comparative uh, baseline and 1 year post periapical X-rays. Okay, this is 6 years post. This is 6 year post, and these comparative X-rays. The other side again. Okay, 6 years, 6 years X-rays. So all the sites at 1 year were able to fully heal or be able to reach a very satisfactory type of clinical situation at 1 year follow-up, considering and what we start from. And I'm not a low-cost type of dental office. So the patient had to pay for the 1 year treatment, this type of amount. But if I had to reevaluate the case at 6 months, the cost of surgical management would have been much higher, money-wise, and not to think about the biological price for the patient that was important. Now we are, of course, in a historical time, and now we are about coronavirus concern. But I've been. This is a video clip that I recorded quite a few years ago. But you will say I had a modus operandi, a way to open up the sterilized envelope and have the patient see that I open and I put in the sterile cloth, because and then the empty bag I put on a side and a different side, not on the same where I put and I also put the gloves at the very end. So that has been my behavior, and also I've been having the patient rinse twice with chlorhexidine, 0.2% or 0.12%. I always have done a double rinse of 0.12% chlorhexidine for 30 seconds, followed by a mucosal scrub. And recently has been published an article in April 2020 that says the only one rinse with chlorhexidine 0.12% will give us immunity from COVID-19 for 2 hours. Okay, so what I think it's important to do a double rinse, because there was an article that I wrote that gives you the idea, and also I've been always teach either the patient or a dental assistant was doing that an intraoral scrub with the chlorhexidine 0.12 prior to any dental procedure, prophylaxis appointment, use of the ultrasonic with a little bit of contaminated aerosol can be created, and so far. Now, this is a specific protocol, okay, that we follow as clinician before starting our working shift, and I like to share it with you. This is the material required, and also we do it also in between work, but we do at the beginning before dressing up, and also we can do it after a few hours of working. And you see, I call it Roncati protocol because it's an initial rinse of 30 seconds using 1% hydrogen peroxide for 30 seconds, followed by a gargle for 15 seconds without rinsing afterwards. And then we do according to what is guideline, zero point 0.2 chlorhexidine, but 0.1 chlorhexidine could be fine as well. So you see, I prefer double rinsing instead of 1 minute 0.2% chlorhexidine. Oh, I'm sorry. I realized that I put the video in Italian. So then a second, okay. Following these 3 rinses and 2 gargle, then I wrap a gauze around the index finger of your dominant hand, and then I dip it in chlorhexidine mouthwash, like that. And then we do 1 tooth at a time, from gingiva to crown, and like a roll type of stroke. Down and and we do all the aspects palatally and as well lingually and buccally of all the sides. Then we take a second gauze, always wrapped around the index finger, and we dip it in 0.12 chlorhexidine, and we do also the soft tissue intraoral scrub, quindi the internal part of the cheeks, inner lips, dorsal and ventral aspect of the tongue, floor of the mouth, and this is very similar to the hospital protocol, and the objective is to significantly reduce the risk of bacterial and virus infection, including COVID-19. Okay, this is a paper note in Italian that I give to my patient to repeat the same type of protocol home. Okay, just wrap a gauze around your finger. You can dip it in a mouth rinse, the one in your hand, and then the patient has to do that with the medicated gauze 0.12, and also can do the scrub as indicated in the protocol. It's very, very, very important that we have, as a clinician, we have to invest time and devote time teaching proper home care, proper home care techniques. And of course, especially if you have implants, I want the patients should use a supplementary tool for the site of the implant. For instance, can be a gauze, a medicated gauze, or a gauze dipped into a mouth rinse. And regarding smart professional care, I personally suggest, especially if you have an external tank, to additionally provide disinfection with using like few drops of betadine, not too many in order not to clog, to get some problem in the system, not to damage the equipment pipes, and then have the double suction, of course, another little, and also wear DPI protection beside doing the protocol that I strongly recommend of intraoral scrubbing to safeguard us as clinician when you are doing a procedure that they have some contaminated aerosol involved. And that is the way I'm working in my practice, especially when we started working again. You see, we opened the windows. Now we have air conditioning on, but still the windows are open, and everything. In order also, let me make also this further comment. Sometime, in order to perform an effective non-surgical instrumentation, not only I have to use the proper technique, but quite often I have to stand up on the left of the patient, on the left side of the patient, if I'm not a lefty clinician, because I have a different perspective, a different point of view, and I can address my instrumentation. I can do a more sophisticated, a more performing professional instrumentation if I change position and I sometimes stand up. Okay, because as I was saying, in the past, everything that was up to 5 millimeters should be managed in a non-surgical in the non-surgical approach. However, everything is above 5 millimeters can be initially managed with a non-surgical approach, but the results are associated with very unpredictable type of outcomes. But even if it is above 5 millimeters, I try with a non-surgical approach, and of course I have to depend on very good hygiene performance by the patient. This was a 11 millimeter pocket that's been reduced in a year to 3 millimeter pocket, and this is the before and after 1 year periapical comparative X-rays, and this is the 6-year follow-up X-rays and clinical pictures. Same patient, different area. Same patient, different area with the 6-year follow-up. At 6-year follow-up, you see on the bite wing, we can appreciate the significant bone fill in that area. However, we can see that the mesial aspect of the first maxillary molar, right molar, and had a big deep pocket, and was to be managed with the surgical approach, because I left a lot of deposit over there that wasn't able to remove. So not always I can solve the problem non-surgically, of course.
Implant.
I hope to have you smile or wake you up if you were not concentrated anymore, because I want to share with you just a few cases that are still with this webinar. I hope that you can still you are still with me, listening to me, and enjoying sharing my cases with you. And but I wanted to shift now to around perimplantitis. So we listen to the video again.
Implant.
Okay, so this is Giorgio. Giorgio was 45 years old, male, and he called me with June the 3rd, 2008, because he was swollen, was in pain. The implant were placed in our dental office, but then the prosthodontist finalized the case and took care, was responsible also for the management of supportive treatment. And so I didn't see Giorgio in the last 3 years, but when he had a problem, he called the office. So you see 7 millimeter pocket depth, and then I took an occlusal view, and I can appreciate like other 7 millimeter of horizontal component of the edema, and the X-rays that I took showed the 5 threads were exposed. And I had the comparative X-rays, comparative X-rays that I can see that there is a progressive supporting bone loss beyond remodeling that can take place within the first year of follow-up. So this is through perimplantitis. And as I saw, the threshold in natural teeth is just 5.4 millimeters, because talking about predictable result of a surgical or non-surgical management. And according to the cyst algorithm, that that threshold is decreased to 5 millimeters. So, however, as I said in the first slide, the non-surgical approach is always the first initial therapy I have to try. And I implement a very similar protocol with this type of appointment. And in the first place, I use the diode laser as well. You see how edematous, swollen, and in pain the patient was, and because it's a very anti-demigenous effect. And also the main instrument to be used are the manual and mechanic instrument, beside the others that you as a clinician can decide to use. As I said, the laser is never a monotherapy. Then I want to see the patient for a short appointment, either the following day, as the Georgia was available, and I took a video clip. You see that the is not swollen and in pain anymore. And also repeat the instrumentation with the proper insert, dedicated insert, and a titanium coated stainless steel curette. And then I see the patient for after a month for a short appointment as well, and I repeat the whole treatment procedure. And then I see now at the first recall appointment, that is at 3 months. As I saw for the first year, I want to see the patient on a quarterly basis, and every time the clinician has to update the diagnosis by circumferential probing. Now the site was 7 millimeter deep, now it's 4. No bleeding now, but we have to wait for delayed bleeding that might occur. So we can wait 30 seconds, and we'll have a slight little bit, like a drop of blood on the adjacent implant, but not on this one. And then I further check with the probe held perpendicular to the long axis of the tooth, as I showed in another previous slide. So everything seems stable. So I keep seeing the patient. No surgery is being performed so far, but I see the patient every 3 months for the first year. And I do a clinical and radiographic reevaluation at 1 year. So this is at 1 year follow-up. You see that I probe, and is not a gentle probing anymore, is a normal pressure probing, proper as indicated in case of implant. So that should be a little bit gentle than compared to natural teeth, of course. Now the follow-up, the first x-rays at 1 year follow-up, and every year up until February. I saw him last February before the lockdown, and I probed circumferentially each time, and is still in a very stable clinical situation. 2 threads are exposed compared to 5 at 2008. So now this clinical case has 12-year follow-up, and was a case report published in the evidence-based literature in 2013. The very last clinical case I want to share with you, talking about prolonging the implant-supported prosthesis survival before the closing remark. This patient is Paula. Paula had implant placed in our office, and she was vulnerable to periodontal disease. So they were replacing periodontally compromised teeth. So she's vulnerable. She's a perio patient. She's not considered healthy patient categories that needs an implant because of a congenitally missing tooth, or because of a trauma, or a decay, very big, or a fracture of tooth that has been fractured, and so on. So as long as she closely adhered to a customized maintenance program, she everything was in a clinical and radiographic stability. Okay, so then the patient started to show a lack of compliance. So I see, and I at the X-ray taken, I see there is a radiolucency around a few threads in this implant. And so I said, Paula, please, let's implement the protocol of perimplantitis. So we'll do that kind of protocol. And the first time, this is the 10-year follow-up. This is a 10-year follow-up. But then the patient failed to return for a period of 1 year. She said that the mother was, we kept calling her. Paula said, I'm sorry, I have to stay with my mother. I cannot leave her, not even for a few hours. So it's impossible for me. When she returned to the office 1 year later, I probed 10 millimeter probing depth, bleeding on probing, of course, and compare to the 10th year follow-up periapical X-ray. Severe localized perimplantitis was radiographically diagnosed at 11-year follow-up. Of course, immediately did pulp test, and the second bicuspid resulted vital. And but I saw very radiolucency, very abundant, very big radiolucency. So I said, Paula, we have to treat it surgically. But the patient rejected. And she said, no way, I cannot treat it surgically because claimed psychological motivation, surgical anxiety, financial consideration. So I said, Marisa, you have to think you can solve it, because remember, I had another problem, another area, compromised. The prosthodontist sent me to you because you need crown lengthening before the final prosthesis was placed. And so you did it with the laser, and everything went well. Okay. I said, no, but it's quite a different type of situation from that. I mean, here we have a huge problem. I cannot possibly manage non-surgically. Paula, is not possible. It's not only predictable, but it's not even indicated. I think I am doing something that is not professionally in my mind to do it for your good health. She refused it. The only thing, I did a different type of surgical technique, and I wanted to widen, make it the peri-implant sulcus widen, and I used the laser with a surgical way, according to similar to a LANAP technique. And then I did look at this, because it will be the final statement. Look at the aggressive I am with the instrumentation. And here, aggressive is absolutely indicated. And I used the devoted insert here because it's an implant. And then this is the clinical aspect at the beginning, and immediately after the non-surgical management after having removed the screw-retained implant supported prosthesis. And then I want to see her the following day. I repeat the procedure, of course, but with the restoration in place. And then I saw the patient 1 month later, and did also biostimulation, and the same procedure. The entire treatment procedure has been removed, including mechanical debridement with ultrasonic and proper insert. And then I see her for the first recall appointment at 3 months, 4 months for baseline, from periimplantitis diagnosis, and of course I did the instrumentation of the whole entire mouth. Then I asked Paola, now listen to me, Paola, you must come every 2 months, because what make things go so worse was your lack of compliance for 1.5 year, for a total of 1.5 year. You were not adhering to the recommended frequency protocol, maintenance frequency. So now you have to come every 2 months. And she did, she came. So you see how the laser goes very lightly, doesn't go deep profoundly, okay? And then, of course, the main important thing is to do to check on use. In this case, I used also hyaluronic acid, but then I did mainly the instrumentation, and also, of course, I did the debridement with the ultrasonic and did biostimulation. And then I saw the patient now, recently, in February, last February, and was 2-year follow-up. And this, the X-ray is a 2-year follow-up. I specified to Paola that my therapeutic goal has been quite modified, because here was not to solve the problem with the non-surgical approach, but was limited. My therapeutic goal was limited to prolonging the implant-supported prosthesis survival, and she very well understood that. However, she had the home care that was spectacular. If we have like an Olympic contest, she win the gold medal, because she was very high performance in cleaning, so forth, and she came bi-monthly in the first year, and quarterly frequency for the following period. This case has been accepted for publication in PRD been accepted. I don't know when it will be published, maybe in 2021. But I didn't show in the title of the article is not the laser assisted clinical outcome, but the title of the article is how home care can impact on laser assisted because she didn't comply. She had periimplantitis. She complied very well. She was able to reach an absolutely unpredictable type of clinical and radiographic outcome. She has good function. She doesn't have any pain. She seems in a quite satisfactory type of clinical situation. So my closing clinical statement and remarks are the following: that the surgical approach always has to follow the non-surgical initial management, and in case of no resolution. And before implant dentistry was available, we were placing a lot of effort in preserving teeth. And also in high quality maintenance care program. And as I told you earlier in this presentation, bone is necessary to achieve osseointegration until the healing process is completed. In case if you place an implant and contextually or later you use like a regenerative technique, you need bone support to achieve and maintain osseointegration for 1 year. After that, well, all you need is the mucocell, is the gingival tissue, because this one is very vulnerable type of situation. This clinical aspect, you can appreciate that there is an adequate quantity and quality of attached gingiva in order to attenuate the peri-implant seal vulnerability features. That's what we wrote in an article in the CDP book, the book of the Italian Society of Periodontology. It was a chapter. in the same chapter, in another different case, you see that either after the implant placement at a later time, we have to add some mucogingival, we have to have some mucogingival management of the area in order to prolong the clinical stability of the implant therapy. And we see here, even if we don't have probing depth, no bleeding, but we see that there is the keratinized mucosa here has some advantages regarding also patient comfort, ease of plaque removal. And here we can see an association with some vulnerability. Even if we probe gently, of course, we can see that can be easily bleeding can be present. It is not firm, is a little bit unstable kind of mucogingival seal in this area. And as I said, you have to do an effective physiological therapy, both with the ultrasonic and with the manual instrumentation. And it's not, sometimes it's not really the type of instrument that we are using. I don't use plastic curette. I don't. I only use titanium coated stainless steel curette, and I can dose my my instrumentation. Then you see, I've been talking a lot about the ultrasonic. I want to spend a few words only about manual instrument. You see how gently I am with an horizontal stroke, and I place like prophy paste, some other kind of dense antimicrobial substance delivered maybe with the disposable syringe and a blunt needle in order to lubricate and to reduce the aggressiveness of the blade. And so I do a gentle here, okay? While here in Paula, because he had the 10 millimeter pocket, I did very aggressive. You see, I'll go 10 millimeter deep with the whole shank of the manual instrument as I go with the whole ultrasonic insert. But I have to be aggressive because we need, in order to do like a site-specific instrumentation, that what I recommend to clinician, okay? And I do vertical, very aggressive. And now you can trust me because of the clinical results that I just showed to you in Paula. I mean, it's one case, it's one clinical case on a case report, which is the lower step in the evidence-based pyramid in literature. Okay, so when going gets tough, the toughs get going. And I want to thank you for your attention. So when it really periimplantitis get very difficult to deal with, we have to wear our war uniform, get really tough, because periimplantitis is going gets tough, and we want to be very I am the periimplantitis revenger. So I want to thank you very much. Want to thank you very much, everybody, for listening, for joining me. Again, I want to say thank you to Macron, who invited me to this to host this webinar. I really enjoyed it. You can understand that you trust me that I say that I'm very devoted to this subject, because I hope you perceive my passion in this professional topic, and my passion for my clinical work in the routine practice. So as I told you, this is my mobile phone. I hope to receive very welcomed WhatsApp message. I always answer. Maybe with an audio message is easier than to write or to send an email. So that is my the way my preferred way to communicate to a colleague. They want to exchange clinical experience and knowledge or comment, simply comment. So thank you so much from Ferrara, Italy. I wish you a good night. I'm sorry again for the technical problem. We are, and I hope you enjoy this time we spent together. Much love to all of you, and thanks again.